Welcome, and thank you for viewing this program. This module discusses brachytherapy for prostate cancer. Prostate cancer is the uncontrolled growth of cells in the prostate, a small gland just below the bladder that surrounds the urethra or urine channel. This common cancer is detected most commonly by the prostate-specific antigen, or PSA, blood test, and/or digital rectal examination, or DRE, and the diagnosis is confirmed by a biopsy, which allows doctors to look at the prostate cells under a microscope. Localized, or organ-confined prostate cancer means that there is no clear evidence of cancer spread outside the borders of the prostate at the time of diagnosis, based on the information available, meaning the PSA, the digital exam, and the biopsy report. There are many treatment options available for localized prostate cancer. Accepted standard options include active surveillance with possible delayed treatment, surgery, called a radical prostatectomy, and two main types of radiation, external beam radiation and brachytherapy. The rest of this module discusses brachytherapy in more detail. Other treatments for prostate cancer available at certain centers only include cryoablation, or freezing of the prostate, high-intensity focused ultrasound, or HIFU, and others. Brachytherapy is a form of radiation therapy that uses radioactive sources that look like seeds or pellets, placed directly into the prostate under ultrasound guidance. In low-dose rate, or LDR brachytherapy, the seeds are left there permanently, and the radiation is given off gradually over a period of months. Each seed, commonly made of radioactive iodine or palladium, is less than half a centimeter long and less than 1 millimeter thick, and is enclosed in a metal case. It is about the size and length of a pencil tip. About 80 to 120 seeds are implanted in the prostate, depending on the prostate's size and shape. They are positioned to evenly radiate the entire prostate plus a margin outside the prostate of just a few millimeters. The seeds give off a dose of radiation that is capable of killing rapidly dividing cancer cells faster than normal body cells, and that is absorbed almost entirely within the prostate. The dose of radiation delivered with brachytherapy is about 1.5 times greater than can be given with external radiation treatments. The term brachy is Greek for short distance. Therefore, brachytherapy means the therapy is at short distance, or treatment of the cancer at the source. Over time, the radioactive material decays. The radioactivity of iodine seeds, for example, decreases by half every 60 days, so that by 6 months, about 85% of the radiation has been given, and by 1 year, it is almost entirely delivered. The inactive seeds remain in the prostate permanently and do no harm. This slide shows graphically how the radioactivity of the seeds decreases over time, such that by 12 months, there is almost no ongoing effect. This also shows that the majority of the therapeutic dose is given initially within the first few months, and then rapidly trails off thereafter. This is important as the side effects of treatment will parallel the time course of the radiation decay. HDR, or high-dose rate brachytherapy, delivers a higher intensity radioactive source, such as iridium, through catheters placed temporarily into the prostate. HDR brachytherapy is often combined with external beam radiotherapy, particularly to treat intermediate and high-risk disease. Like LDR brachytherapy, it is not available in all cancer centers. Its side effects are similar to LDR therapy, but do have some differences that should be outlined by your treating physician. The remainder of this module will address LDR brachytherapy specifically. Patients are eligible for brachytherapy based on disease factors and patient factors. In the case of intermediate or high-risk prostate cancers, brachytherapy may be most effective in combination with either hormone therapy or additional external beam radiotherapy. The specific disease criteria and treatment recommendations will vary with treatment center and may change over time. Patient factors that are important include the baseline health of the patient and any competing medical conditions. Generally, patients should have a life expectancy of 10 years or more. A smaller prostate size can be more favorable, although this is not a strict criteria. In the case of larger prostates, the oncologist may suggest hormone therapy to shrink the gland prior to the procedure. Good basic urinary function allows patients to better tolerate the procedure. Patients with a history of prior prostate surgery, such as transurethral resection of the prostate or TURP, may have more challenges with brachytherapy and thus require a thorough discussion with an experienced physician. Most men with prostate cancer will have been seen by a urologist, who is a surgeon specializing in the urinary and male reproductive systems. This doctor will make the initial diagnosis and discuss treatment options. The urologist may offer brachytherapy as an option, or may make a referral to a radiation oncologist, who is a physician specializing in the treatment of prostate cancer with radiation. During the consultation, the doctor will determine a patient's eligibility and suitability for brachytherapy and discuss the advantages and disadvantages of the procedure. If a patient is eligible for brachytherapy and chooses this as his treatment, then planning for the seed implantation will begin next. A few weeks to months before the implant procedure, the urologist or radiation oncologist will make a detailed map of the prostate using a transrectal ultrasound, or TRUS. This is a procedure that uses a small ultrasound probe inserted into the rectum to accurately gauge the size and position of the prostate. In some centers, the ultrasound procedure and treatment can be done all in one day, with the ultrasound being performed at the start of the procedure after you are under anesthetic. This is called real-time planning. The oncologist, a radiation physicist, and a dosimetrist, a person who calculates a proper radiation dosage, aided by computers, will use the ultrasound results to determine the number and strength of seeds needed to treat the cancer and exactly where the seeds should go. This image shows a sample screenshot of the computerized programming of a treatment plan. Brachytherapy takes about 1 hour to complete and is usually an outpatient procedure, meaning it does not require an overnight hospital stay. Typically, patients go home within a few hours after the implant and return to work and normal activities within a few days. The night before the implant, patients will need a bowel preparation. This may be either a medication to swallow or an enema. Patients should ensure that they know the specific preparation at their center. In addition, in the weeks leading up to the procedure, patients are often given a medication called an alpha blocker that relaxes the neck of the bladder, allowing urine to flow more freely. This medication may be continued for 3 to 6 months following the procedure to help decrease prostate swelling and prevent and treat urinary symptoms that can occur. On the day of the procedure, the nurse will review your medical history and check your vital signs, including your blood pressure, pulse, and temperature. An intravenous or IV line will be started, through which you will receive fluids and later medications. An enema is given in some centers, if not done so already the day before. You will then meet with an anesthesiologist, who will administer anesthetic drugs and monitor your vital functions during surgery. The anesthesiologist will review different anesthetic options with you and discuss their merits and potential risks. Finally, prior to surgery, you will meet once more with your radiation oncologist or urologist, and any final concerns will be addressed. Once in the operating room, an intravenous or IV line will be started if not done so already. You will then be put to sleep by the anesthesiologist, and a breathing tube will be introduced. In some centers, the procedure is performed using spinal anesthesia given through a needle in the back, which freezes a patient from the waist down. Other tubes and monitoring lines may then be placed, including a catheter into the bladder. Once the patient is anesthetized, an ultrasound probe is placed in the rectum, and the prostate is inspected using sound waves from the ultrasound device. The picture of the prostate generated in this way is used to guide the placement of the brachytherapy seeds. The seeds are loaded into individual needles and passed through the perineum, which is the area between the scrotum and anus, and into the prostate. As the needles penetrate the prostate, they are seen on the monitor and can be accurately guided to their predetermined position. When each needle is in its correct position, the needles are slowly withdrawn, leaving the seeds behind. This slide shows the typical setup, with the ultrasound probe in place in the rectum to guide the passage of the needles, which contain the radioactive seeds. This X-ray shows an example of the radioactive sources distributed throughout the prostate. Computerized programming, as displayed here, demonstrates the distribution of radioactivity in the prostate. Refinements in technology and surgical technique allow doctors to place seeds into the prostate as precisely as possible to ensure that maximum radiation is delivered to the prostate to kill all cancer cells, while at the same time limiting the amount of radiation to surrounding structures. You can appreciate in this drawing that several important organs and structures lie immediately next to the prostate: the bladder, the rectum and anus, the urinary sphincter or valve muscle, and the erectile tissues of the penis. Radiation to any of these can lead to certain side effects. In the following slides, we refer to the common side effects of low-dose rate brachytherapy alone. The timing of early side effects will follow a similar time course as the decay of the radioactive sources. These early effects are due to both the initial swelling of the gland caused by physical trauma of the procedure, and secondarily by the inflammation caused by the radiation to the bladder, prostate and urethra, and rectum. The early urinary and bowel side effects peak in the first 3 months, and these gradually improve by 6 to 12 months as the linings of the urinary tract and rectum heal. The most common side effects of brachytherapy are bladder and rectal irritation and minor discomfort. Bladder symptoms are most common, with up to 80% of men experiencing urgent and frequent urination, especially in the first 2 months after the procedure when radiation is most intense. These symptoms may persist for up to a year. About 1/2 of men experience burning with urination, which peaks at about 1 month after treatment. Bladder symptoms may be lessened by the use of medications called alpha blockers beginning before treatment. It is also helpful to reduce caffeine and smoking, and to use anti-inflammatory medications as necessary. Fortunately, although side effects are common, they are also very treatable with medication and other therapies. Acute urinary retention occurs due to swelling and stiffening of the prostate from the effects of radiation. This is most likely in patients with large prostates who already have significant urinary difficulties. Urinary retention occurs in 5 to 10% of patients, and most often requires a temporary urethral catheter for approximately a week. In a small percentage of men, it may persist 6 months or longer. Finally, scarring in the urine channel or urethra, called a urethral stricture, occurs in 5 to 10% of men after brachytherapy and can also block urine flow. As noted in the previous slide, in very rare cases, men may experience prolonged urinary retention following LDR brachytherapy. This may require long-term use of a catheter or tube in the bladder, placement of a suprapubic catheter, which is a tube into the bladder through the skin at the base of the abdomen, or rarely surgical removal of part of the prostate, called a transurethral resection of the prostate, or TURP or TURP. The TURP procedure is described in a separate module. If this surgical procedure is required, the surgeon must be especially careful, as it is riskier to do after brachytherapy than in non-radiated men. There is a higher chance of causing permanent loss of urine control or damage to the rectum in these patients. Patients should speak with their doctor about their individualized risk of complications. Mild, self-limiting rectal irritation affects 20 to 30% of patients in the first 1 to 2 years after the implant. Rectal bleeding can occur in about 10% of patients and is also usually self-limiting. 1 to 2% of patients may require a laser photocoagulation procedure, which is a minor procedure done during colonoscopy which prevents further bleeding in 90% of cases. It should be noted that if a colonoscopy is performed in a previously implanted patient, biopsies of an irradiated region of the bowel should be avoided. More information on the management of bowel side effects can be found in a separate module. Burning with urination and blood in the urine are also common, short-lived side effects, as is some mild discomfort and bruising in the perineum, the space between the scrotum and the anus. Some blood in the ejaculate or painful ejaculation may also occur for as long as 6 to 8 weeks. Stomach upset and lower abdominal pain are also described by some men. Fatigue is usually mild but may occur in the first few months following implantation. In addition, some seeds can make their way out of the prostate into nearby or even distant tissues such as the lung. However, since usually only very few seeds migrate elsewhere and the dose of radiation is very low for each individual seed, the total dose to these other areas like the lung is very small and not harmful. Specific safety instructions are usually given shortly following your implantation. While the radiation from seeds is generally not harmful to others, a patient might be advised to avoid close contact between the lap and very small children and pregnant women for the first few months after treatment. Radiation from the seeds will not affect electrical signals or devices, but can set off radiation detectors when crossing country borders, like the USA and Canada. Therefore, your doctor will give you a card that states you have had this procedure and that you are safe to travel. Another unusual caution is that patients may not be cremated in the 2 years following their implantation. This is to avoid any small amount of residual radiation in the seeds from being released into the atmosphere by this process. Urine control problems after brachytherapy are different than those that might occur after surgery, and are usually due to bladder irritability from the effects of radiation, causing what is so-called an overactive bladder. This results in frequent urination and sudden urges to urinate which are more difficult to control, and can lead to what is termed urgency incontinence. You may watch the module on overactive bladder to learn more about how this condition is managed. These symptoms are usually short-lived and occur generally in the first few months following the implantation. In a small percentage of men, less than 10%, they may persist and symptoms may be difficult to treat. They may require the long-term use of medications to relax the bladder and/or the prostate muscle. The sphincter or urinary control valve muscle can also be weakened by radiation, although this rarely has any noticeable effects on a man. In severe cases, it could cause leakage with coughing and straining, called stress incontinence, but again, this is rare unless a prostate resection, or TURP, has also been required. Rare side effects can occur to the bladder or bowel in less than 5% of patients. A urinary stricture is a blockage of the urine passage caused by scar tissue. This is a relatively rare complication in men and is caused by the radiation narrowing the passageway of urine flow. It can be treated by dilating the urethra or by surgically opening up the scarred tissue, referred to as a urethrotomy. You may refer to a separate module on urethral stricture for more information on its management. A scar or ulceration of the rectum is rare, but caution should be taken to not biopsy this area when performing a colonoscopy, as this can lead to greater complications. Very rarely, in less than 1 of every 500 to 1,000 patients, a hole can open up between the bladder and bowel or skin. By diminishing any trauma to these surrounding tissues, such as biopsies or surgical interventions, the risk of this complication is significantly diminished. Second cancers caused by brachytherapy are much rarer than those caused by external beam radiotherapy. There is still a theoretical risk to be aware of, and this can be discussed individually with your oncologist. The risk of erectile dysfunction, or ED, following radiation varies widely and is dependent on a number of factors, including pre-existing ED, the use of other treatments and other medical conditions that may affect erections, age, smoking, obesity, and medical problems such as diabetes or high blood pressure. Of all treatments, brachytherapy does the best job of preserving erections early on after treatment. Having said that, it is important to understand that, while erections may be well preserved after brachytherapy, the effects of radiation continue to affect the body's tissues for years, and the quality of erections in some men may begin to worsen several years after treatment. The overall risk of ED after brachytherapy ranges from 30 to 50% and is similar to people having nerve-sparing surgery. However, it occurs a number of years after the procedure rather than immediately afterwards, as it can following surgery. In young men, it is important to note that even if erectile function is preserved, a man will be infertile. If this is important to a patient, then fertility options should be discussed prior to receiving brachytherapy. Here we will make a quick note that in some cases, some men may require that brachytherapy be combined with hormone therapy to shrink the prostate prior to brachytherapy, or external beam radiotherapy to maximize cancer control. In these cases, men must understand that hormone therapy has its own side effects and may worsen or prolong sexual side effects, or that external beam radiotherapy may increase the risk of bladder and bowel side effects and erectile dysfunction. Therefore, patients should review with their oncologist their specific risks related to their radiation treatment plan. Hormone therapy and external beam therapy are discussed in their own separate modules. Typically, in 1 month following the implant, or in some centers on the same day of the implant, patients are required to return to the hospital for X-rays, a CT scan, or possibly an MRI scan. This follow-up CT or MRI is needed to determine the quality of the implant that was performed. The diagnostic imaging scans are used to calculate the dose of radiation received by the prostate and to determine how good an implant was performed. Very rarely, if anything unexpected is found on the diagnostic scan, a patient may have a second procedure to place additional seeds if required. In these very rare instances, the oncologist will discuss the individualized case directly with the patient. The PSA, or prostate-specific antigen, blood test is a sensitive marker following treatment of prostate cancer. After brachytherapy, patients are monitored closely with PSA tests on a regular basis, along with an annual digital rectal examination, or DRE. A steadily declining PSA is a good indicator that the treatment has been successful in killing the cancerous cells. It is important to understand that, compared to surgery, after radiation the PSA level will not drop to 0 because the prostate is still intact. The PSA level should drop, however, to a low level where it stabilizes more or less. In patients following brachytherapy, the PSA will actually decline faster than in those patients following external beam radiotherapy. That being said, it may still take several years for the PSA to reach its lowest level and eventually become undetectable. Should brachytherapy treatment not have been successful, or if the cancer recurs, meaning that it comes back, a few other treatment options are available. Cryotherapy, which involves freezing and destroying cancer cells, may be used as a second attempt at cure or control, and rarely a prostatectomy, which is a surgery to remove the prostate, may be performed. In either case, the chance of complications from these procedures is higher after brachytherapy than in previously untreated men, as the radiation affects the tissues in the prostate and surrounding structures. Further radiation is not usually recommended, as it may cause further complications. However, a focal repeat implant could be considered, but this needs to be discussed directly with the oncologist. The other type of treatment available for recurrent disease is hormone therapy, which involves medications or surgery to stop the production of the male hormone testosterone, which fuels the growth of prostate cancer. To summarize, low-dose rate brachytherapy, or LDR, is a type of radiation treatment for prostate cancer that uses small radioactive seeds placed in the prostate to eliminate cancer cells. It treats the cancer at the source by emitting radiation and causing cancer cell damage locally, thereby minimizing the radiation effects on neighboring tissues and organs like the bladder and rectum. Depending upon the risk of the cancer, it may be used alone or in combination with hormone therapy or external beam radiation. It involves consultation with a radiation oncologist and implant planning using an ultrasound. It is a short, minor surgical procedure that uses general or spinal anesthesia and does not require an overnight hospital stay in most cases. Brachytherapy is well tolerated. There is minimal discomfort afterward, and the majority of side effects are minor and short-lived. Brachytherapy can, however, affect a man's urinary and sexual function, and this is important to understand and discuss with your oncologist. Thank you for viewing this educational program.